So the next few minutes, I'll be speaking about developing multicentric collaborations and why I think it's a great idea. So before we go there, what we did about 7 or 8 years back was to look at the cancer research scenario in India, and you'll see a lot of familiar names in this paper, was to try and identify where the gaps were and what should be our strategy to address these gaps over the next few years. So a brief summary of that fairly voluminous paper is the fact that in low middle income countries such as India, there was an urgent need to start training in research methods. There needed to be protected time for research for clinicians, given their busy clinical schedules. There needed to be a lot of support for logistics for the conduct of studies. And all of us who have done trials know that having a great research idea is one thing, and to actually convert it into an implementable research study is something entirely different. And given the pressures on time that clinicians in India have, the logistics become all important. The fourth is very important, and again, something which is the substance of the next few minutes of my talk, which is finding collaborators and finding the right collaborators. As many of the previous speakers spoke, having an inequity in the collaborations that you have can often lead to not the greatest of studies and not the greatest of implementable outcomes. There also was a need for ongoing mentorship in research and the need for funding. And I just mentioned this because this came about as a part of a gap analysis done 8 years back. And what we did as part of the National Cancer Grid was to try and identify and find solutions for each of these 6 points that we had identified 8 years back. So this is something that you've heard about many times over the last session. The predicted global cancer cases is likely to increase. And here there's a fairly differential increase that you see. The magnitude of increase that you see in low middle income countries far exceeds that of high income countries. And that is the reason I think we need to do research which is relevant to our own setting. So when we start talking about research in global conferences, and as Chris said, in conferences like ASCO and ESMO, you start hearing about the cutting edge technologies like robotic surgery, proton therapy, targeted therapy, precision medicine, immunotherapy, and the latest kid on the block, CAR T-cell therapy. And while all of these are extremely good, very and really great breakthroughs, what we fail to understand is that the vast majority of patients in low middle income countries are unable to afford these patients. And clearly, a solution that fits only 30% of the world's population is not something that we should actually celebrate as a breakthrough. So this is another version of similar slides that you've seen in the previous session, the median cost of cancer therapy over 5 decades. And as you can see, there's a fairly linear increase in the costs of care that you see. And for those of you who think that this kind of an increase is acceptable given inflation, I must point out that the y-axis is actually on a logarithmic scale. So the average cost of cancer therapy 5 decades back was $100 per month, and it's gone up to when in 2015, $10,000 and now $12,000. So clearly this is not sustainable in low middle income countries and possibly even in many high income countries as well. And the US is beginning to realize the burden of high healthcare costs even in a high income country. I'll take you through this comparison of global research priorities. And this is again American data. The column that you see on the left is a measure of cancer deaths as seen in the US. And as you can see, lung cancer accounts for 20% of all cancer deaths. But if you look at the American Cancer Society research funding, you see that there's virtually no correlation between the burden that you see in the US and the amount of research dollars that are spent on it. So for example, a cancer which accounts for 20% of all cancer deaths gets funding of under 8%, whereas a cancer which accounts for 6% of all cancer deaths gets funding in excess of 15%. So clearly there's virtually no correlation between this. And again, this is something that Chris showed in his talk, virtually no correlation in close to 700 randomized trials in cancer which were looked at. And not only was there no correlation between the burden and the prioritization, 90% of them led by high-income countries, almost 90% tested systemic therapies, which meant that just 13% tested all other forms of research in cancer. Low middle income country randomized trials were less likely to be industry funded, more likely met the primary endpoint and had a larger effect size. And in spite of that, were published in journals with a lower impact factor, regardless of whether they were positive or negative. I'm not a big fan of the impact factor, but for lack of a better metric, which looks at the visibility of a paper, I think this clearly points towards a publication bias. Turn the clock back 15 years, and the study which was done out of the Tata Memorial Hospital, which looked at the access to trastuzumab, which, as all of us accept and acknowledge, is a true breakthrough in the management of breast cancer, something which had substantial benefit. And when we looked at all the patients who are eligible for trastuzumab, these are HER2 positive patients, we realized that only 8% of these patients actually received the drug. And out of these 8%, half of them received it only because they were part of a clinical trial, and only 4% of patients were able to afford this. So clearly, solutions that are fit for purpose in the West may not be applicable to countries like India. Which brings me to the main topic of my talk today, which is on building collaborations in research. There have been a lot of bad things that happened over the last 3 years, thanks to COVID, but there have been some good things that came out of the pandemic as well. And I can't think of a better example of how collaborations have driven COVID research as much as the recovery trial. So if you look at the design of this trial, it was a large pragmatic trial, over 12,000 patients involving 176 hospitals. And most importantly, they recruited 13% of all hospitalized patients in the UK. So 13% of all patients with the disease getting recruited onto clinical trials is something which is phenomenal. And this is primarily driven by the fact that there was a huge administrative push to include these patients in trials. And the then Chief Medical Officer of the NHS, Chris Whitty, actually said that the use of treatments outside of a trial where participation was possible is a wasted opportunity to create information that will benefit others. And I think the recovery trial has been a phenomenal example of how this philosophy has helped recruit patients very rapidly. So the recovery trial has so far answered several questions. I'm not going to go into detail in many of them. These were questions which were unanswered, whether oxygen was useful, whether dexamethasone was useful, hydroxychloroquine. And if you put yourself back 2.5 years back, the kind of controversy that these drugs had created were clearly important questions to answer. So my argument here is that this was not an accidental hit. It was not fortuitous that they were able to randomize 12,000 patients in 176 hospitals in a very, very short time to answer questions when the question was relevant. The most important fact is the point that it was backed by the establishment. As I mentioned, the chief medical officer putting their weight behind the increased recruitment of patients onto this trial. The UK explicitly prioritized this trial over others. So if you try and spread the small patient pool across several trials, you're likely to come up with many trials, none of which are likely to provide definitive answers. So putting the weight of the entire establishment behind one large pragmatic trial, at least for this clinical scenario, seemed to make a lot of sense. And again, the design that was used, which is the multi-arm, multi-stage study, which I think one of my colleagues, Amandeep, described in extreme detail in one of our hospital meetings last week, this was not something that they could have dreamt up within a week's time. This was something that had been used in the Stampede trial for prostate cancer. And the fact that they had this ready design available, and it's a fairly complicated design, and it's not something for beginners to start with. Well, the fact that they had this ready design from the MRC clinical trials unit and enabled them to launch a similar trial on COVID-19 as well. So we've had certain preparatory steps that we have taken at the Tata Memorial, one of the most important of them being the Department of Atomic Energy Clinical Trials Center, modeled on the lines of the MRC CTU, but on a more modest scale, which was established in 1996 and rechristened as the Clinical Trial Center in 2003, thanks to Dr. Badwe, who started this, which support clinicians with the nuts and bolts of doing studies, and has so far supported several pivotal practice-changing trials at the Tata Memorial. They've also conducted several training programs, some of which many of you have participated in as well, as either as a participant or as faculty. And they also conduct the regular annual meeting on evidence-based management of cancers. So the result of all of this has been that we've had several trials which have changed practice globally. Many of you are aware of the the randomized trial on elective node dissection in head and neck cancer. which showed a 10% improvement in survival. The effect of VIA screening in cervical cancer, 150,000 women randomized to screening with VIA or awareness alone, which again showed a 30% reduction in mortality because of cervical cancer. The sister study for this, which was the clinical breast examination, which again showed a 30% reduction in mortality. The M0 trial for breast cancer, which demonstrated that operating on the primary in metastatic breast cancer did not improve outcomes, answering a long-held question in breast cancer management. So many of these have been thanks to the fact that the infrastructure and the logistic support was available at the Tata Memorial. And it's also thanks to the fact that it enabled these kind of trials to go on. So with the creation of the National Cancer Grid 10 years back, we wanted to extend this a little further. And as I mentioned in 2014, the gaps that were identified were systematically attempted to be solved subsequently. So for those of you who are not aware, it currently stands at over 270 cancer centers, research institutes, patient groups, and professional societies and charities across the country, which between them treat over 60% of all of India's cancer burden. And the main mandate of the Cancer Grid is to have uniform standards of care, developing trained human resource, and collaborative multicentric cancer research. So those of you who heard about cancer care and education under the NCG are probably aware of the resource stratified guidelines, the second opinion or the expert opinion service, the virtual tumor boards, the massive open online courses that are run under the NCG, the collaboration with the Ayushman Bharat, which is the largest insurance scheme in India for health, and the launch more recently of the Center for Global Health under the National Cancer Grid. But here I'm going to focus on the research aspects and the collaborations that it has helped foster. So with the creation of the clinical trials unit and the contract research organization, one of the gaps that were identified in the 2014 paper was addressed to a large extent. So having realized the benefits of having a clinical trial center at the Tata Memorial, we wanted to extend this to other centers which were part of the Cancer Grid. So this functions on a national level with help with study designs, biostatistics, regulatory submissions, and for most of these which require a lot of paperwork like multicentric studies, contracts, insurance, and monitoring, the NCG CRO and the CTO is able to help them at a fraction of the cost that a commercial CRO would be able to offer. The CLIO workshop is something which many of our current faculty are faculty in, and they love coming back to this year on year, primarily because the outcome of these workshops has been extremely rewarding. Close to 300 participants have benefited from participating in this workshop over the last 6 or 7 years. And what happens is that participants are selected through a process which is internationally peer-reviewed. They come in with a one-page research summary, which is a vague idea in the back of their mind. And at the end of 6 very intensive days of participating in the workshop, they go out with a full-fledged research protocol that is ready for ethics submission. And it's kind of a hackathon on how to do research. Having gone through the research, the workshop, many of our participants came back with feedback that they would want ongoing mentoring. So we started the virtual research boards, which continue to mentor participants and even those who have not participated in the CLIO workshop on specific issues they might have in study designs or biostatistics. So if those of you are interested, this is a publication on the workshop which describes it in more detail. One of the gaps that we had identified in 2014 was the issue of funding. So there have been initiatives which are looking at systematically identifying gaps in evidence and answering them. We call this the National Cancer Research Initiative. And we also fund cancer research through the National Cancer Grid, provided these criteria are met. First, it needs to be a multicentric collaboration. And I think we did this very deliberately because we had been far too comfortable doing single center studies, and we wanted to get clinicians and researchers out of the comfort zone and to realize the benefit of multicentric collaborations. And we've been fairly successful, and I'll describe that in a subsequent slide. The cancer that is being studied is something that needed to be common or unique to the region, thereby ensuring that something that is a contextually relevant issue is the one that's getting addressed. The intervention, if it's an interventional study, it needed to be cost effective so that there is no gap between a successful study being implemented in the real world. And any researcher who's funded through the Cancer Grid has to commit to share their data in the public domain. And increasingly, more recently, we've had a very strong emphasis on public and patient involvement right from the design of the study. So these are some of the studies that the Cancer Grid has funded. And then point your attention to many of these studies. So if you look at the Icicle study, which is a study on pediatric AML, the sample size is over 2,200. So just to give you context, most studies in pediatric AML have recruited patients globally through cooperative oncology groups in the range of 300 to 400 patients. So you have the ability to scale this up much higher with using collaborations. And this is probably 11 or 12 centers, high volume centers across India that are contributing to this study. The second is something on, it's a 2x2 factorial design looking at curcumin and metformin as adjuvant therapy in head and neck squamous cell cancer. And if you look at it, this is using something which is indigenously developed, curcumin. We've had a lot of hype about curcumin being an anti-cancer agent, but very little strong phase 3 data to support it. So we decided to fund this study to see if it was truly beneficial for patients with head and neck squamous cell cancer. The metformin part is a repurposing aspect of the drug, and we're hopeful that with this study, we'll be able to answer 2 questions. There's several other studies, and if you look at it, the funding that these studies have required are probably a fraction of the cost that it would otherwise require if we were to conduct this in a high-income country. So collaborations, and especially collaborations within low middle-income countries, seems to be an extremely important aspect of how we do research. More recently, we received funding for creation of the NCG Center for Digital Oncology. This is actually funded by the Koita Foundation, which is supporting us with about 25 crores over the next 5 years, looking at how we can leverage digital health solutions to make solutions easier for our patients. And we look at the entire gamut of issues with digital health, including the creation of something as basic as the creation of an electronic medical record, going on to more advanced AI machine learning projects, looking at how we can use machine learning and natural language processing to reduce the dependence on clinicians and scarce oncologists in this effort. I'll take a minute to speak about the AD-aspirin trial, which I think is one of our success stories with collaboration. And this was a really ambitious study. I remember having a sandwich with the then newly appointed director of the MRC Clinical Trials Unit, Max Parmar. And basically, I'd gone to visit the MRC Clinical Trials Unit because I had taken over the Clinical Research Secretariat at Tata Memorial, and I wanted some tips and tricks on how to make it scalable and get better. And he casually mentioned to us that they were doing a meta-analysis on the use of aspirin from observational studies on colorectal cancer and several other cancers. And this got us talking, and the emphasis that we have on repurposing of drugs, and what turned out to be a very casual conversation over coffee ended up with a very large multicentric international trial, which will answer the question of whether adjuvant aspirin after radical treatment in 4 of the most common cancers globally, which is breast, esophagogastric, colorectal, and prostate, whether the use of 2 different doses of aspirin, 100 milligram or a 300 milligram compared to placebo, would improve outcomes after radical treatment of these cancers. And again, this is an umbrella study, which is looking at these 4 cancers, which between them will randomize over 9,000 patients to either of these 3 arms that I just mentioned. So a collaboration like a trial of this nature would probably be unimaginable if it weren't for collaborations. And it comes back to the fundamental point that even if we are a high volume, large cancer center, we should probably invest much more in collaborations than trying to do it otherwise. Not just recruitment becomes faster and more efficient, it also makes the results more generalizable than if you were to restrict it to a single study. One of the biggest regrets that I have with some of my own personal studies have been the fact that we've not gone multicentric when I started it. I was younger, naive at that time, but I don't think I'll make that mistake anymore. A lot of these are addressed in a recent paper that we wrote about what should be the priorities for cancer research in low and middle income countries. And the summary of this paper is that we need research that is locally relevant and it is critical in low middle income countries. Institutions need to invest into the research ecosystem and set up the infrastructure to facilitate research. Training in research methods builds capacity, and they have most low middle income countries have a large and as yet, as you saw in several talks in the previous session, and so far untapped potential to do globally impactful research. But if I want to leave you with one single message at the end of this talk, it would be to collaborate, collaborate, and collaborate, because clearly this is a far more efficient way of doing research than we otherwise would. Thank you very much for your attention.